hypercholesterolemia as a side effect. That's what I refer to here as xenobiotics. And one of those drugs, the group of drugs, will be your beta antagonists. Beta antagonists predispose patients to hypercholesterolemia. Now, what is dyslipidemia or hyperlipidemia? You should be able to know that this just means dysfunction. Hyper means it is high. So let's waste time on that. Now, the nature and the role of lipids. You all know from the biochemistry that lipids are non-polar. Because of that, that means they are insoluble or barely soluble, especially when they find themselves in aqueous medium. But then, they are very important in many biological functions, and their functions are listed here. And cellular membrane integrity, because we know there's a phospholipid layer in the cell membrane. They are a source of stored energy. They are required for the biosynthesis of steroid hormones. I'm sure you have treated that. The formation of sex hormones, corticosteroids, and all of that stands for cholesterol. So these lipids are required for the biosynthesis of steroid hormones, also for the synthesis of vitamin D, and they serve as signaling molecules that carry messages from one part of the cell to another. But because they are non-polar, they need to be transported through the aqueous media of the blood. So the way they do that is they are packaged with special proteins that we call apoproteins. And when the apoproteins combine with lipids, that's what we refer to them as lipoproteins. And we will treat these lipoproteins as we go through this slide. These lipoproteins, therefore, become lipid transporters or carriers, since they will have to combine with the lipids in order to transport them from one part of the body to another. And when you have altered serum concentrations of certain types of these lipoproteins, that's when you associate them with atherosclerosis. What are these major transporters of lipids? They're either chylomicron, very low density lipoprotein, low density lipoprotein, which is your bad cholesterol, or high density lipoprotein, is good cholesterol. All of these are major transporters of lipids. And through these carriers, they can leave the tissue of origin and move to enter the bloodstream and get to the tissue where their components can be used in those functions as listed in the previous slide. So they can be used for synthesis of vitamin D and steroid hormones. They can be used for oxidative processes. They can be stored as energy reserve. Now, to talk a little more about apolipoproteins. These are now the apoproteins of lipoproteins. Don't forget, lipoproteins are the protein combined with the apoproteins. But then when you have apolipoproteins, these now become the apoproteins of lipoproteins. And these are amphipathic proteins that wedge themselves between the surface layer of lipoproteins. And a number of them contain one or more protein. What do they do in this context? They provide structural stability. They act as ligands, especially for specific lipoprotein receptors. And these specific ones can either be ApoE, ApoB100, ApoB48, and ApoA1. And they can also act as cofactors for various enzymes that are involved in lipoprotein metabolism, like ApoC2 and ApoC3. And I'll mention some enzymes that are involved in lipid metabolism, like lipoprotein lipase. Later on, lipoprotein lipase, when I mention that, these are the ones that are used in lipolysis. They break down fat, and they use this ApoC2 and C3 as cofactors. Then the last but not the least is that the composition of the apolipoprotein will determine the metabolic fate of the particular lipoprotein. So with that, we talk about hyperlipidemia or dyslipidemia as a major risk factor of cardiovascular disease. Now know that atherosclerosis is a disease of the blood vessels that supplies different tissues. If we're talking about the plaque that blocks the arteries that go to the heart, you end up with a osteoma. Now that's the one that causes heart attack. If it's the one that goes to the brain, you talk about stroke. If it goes to the lips, we talk about peripheral vascular disease. If it goes to the kidneys, that's the one that causes kidney failure. And of course, I'm going to treat this, and this as part of this course as we go along. So cardiovascular disease risk due to atherosclerosis can be reduced. You can even prevent it. And how do you do that? You've got to do mainly lifestyle changes and pharmacological interventions. Since we know that we know the risk factors, smoking, antibiotics, alcohol, and the rest of them, and diet, lifestyle changes can do that. Because of obesity is a major risk factor for it too. You can do lifestyle changes. And combining that with pharmacological interventions is a way to eliminate hypercholesterolemia. See, hypercholesterolemia is not like hypertension, but like essential hypertension I told you last week. Essential hypertension has nothing you do, that person has it for the rest of it. You can just manage it. For hypercholesterolemia, you can eliminate hypercholesterolemia through lifestyle changes and pharmacological interventions. So what is the risk of dyslipidemia or hyperlipidemia? This is closely related to whether you have elevated bad cholesterol or you have a reduction in good cholesterol, HDL. You can also have high levels of triglycerides, but this one is an independent risk factor. It's not tied to anything. But then when you have high levels of triglycerides combined with low amounts of good cholesterol, then you can have an increased risk for atherosclerosis. When you look clinically, you can divide dyslipidemias into 4 types. There's hypercholesterolemia, which we're mentioning, hypertriglyceridemia, mixed hyperlipidemia. When you have mixed hyperlipidemia, it means there's high cholesterol, there's high triglycerides. And when we talk about the high cholesterol, of course, we always refer to the LDL. Of course, you also have the other transporter proteins, the chylomicron, very low density lipoproteins, as that will feature in this case. So when you look at this slide, it talks about the classification of hyperlipidemia. It could be primary if it runs in the family and is hereditary. And this is the one that is genetically determined. And there are 5 major types of them, types 1, 2, 3, 4, 5. And this is associated with specific lipoproteins that are increased. For example, in type 1, you have an increase in chylomicrons, not any other one. And in type 2A, you have an increase in low density lipoprotein. In 2B, you have low density lipoprotein and very low density lipoprotein. In type 3, you have intermediate density lipoprotein. In type 4, you have just very low density lipoprotein. And in type 5, you have very low density lipoprotein and chylomicrons. So depending on which of them you have, you can have what names they are called. For example, because it's only chylomicrons that are increased here, we call it familial chylomicronemia. Because this is just the cholesterol, the bad one, we call it hypercholesterolemia. So whichever case it is, mix of things. I will not punish you by asking you these ones that are mixed. The ones I may likely ask you, I may say type 1 hyperlipidemia is associated with what? Type 3 or type 4. I'm not going to ask you the ones that are mixed. So if you're able to say type 1 is for chylomicrons, type 3 is for intermediate density lipoprotein, and type 4 is an increase in very low density lipoprotein. I will let you rest easy. Okay? Now, just like we have primary hypertension and secondary hypertension, you have primary hyperlipidemia and secondary hyperlipidemia. Now, of course, in secondary hypertension, that is the one that you know its cause. It is caused by drugs, it is caused by disease. In this case, the secondary hyperlipidemia is acquired hyperlipidemia. And there is hypercholesterolemia, which can be caused by diseases and drugs, just like you have for hypertension. So in this case, what are the diseases that can cause hypercholesterolemia? Hypothyroidism. This should be easy for you to figure out because you know when individuals are hypothyroid, their metabolism is low, right? So definitely cholesterol will accumulate. So I will expect you to know hypothyroidism would be a form of secondary hyperlipidemia. Nephrotic syndrome. I treated nephrotic syndrome for you last year too, and we mentioned about hypercholesterolemia in the pathophysiology of it. Then the other one is your hypertriglyceridemia. This can be caused by diabetes mellitus, that's DM. Diabetes mellitus can be caused by alcohol abuse. Could result from gout and could result from chronic renal failure. So I will ask you a question around this and say, if I say which of these conditions can lead to secondary hyperlipidemia, that put hypothyroidism there, then you know that's correct. No? If I put diabetes mellitus is more related to triglycerides than to cholesterol. Now, what are the guidelines for different lipids in terms of what is normal or optimal or what is high? Usually for the bad cholesterol, it's advisable that it's less than 100 milligrams per deciliter. The total should be less than 200. For triglycerides, it's less than 150. And for high density lipoprotein, it should be more than 40. It should be more than 40. If you want to change in your note so that you don't get confused, 40 is your reference point for high density lipoprotein. So you're just saying if it's less than 40, you consider it as low. But normal would be when it's greater than 40. Yes?
What guidelines are we following for this one?
Huh?
What guidelines are we following?
These guidelines is the National Cholesterol Education Program.
Okay.
NSET.
So, sir, you said the 40, it should be lower?
No. 40 is like the threshold. It should be higher than
Okay.
40. So if it's less than 40, it's considered low.
Low.
If it's 40 and above, that's where you want to be. So any other thing, is then fine. So what would now be considered borderline? For example, here, when the total cholesterol is between 200 and 239, is borderline. But anything higher than that will be considered high. And the rest of the information is there. So let me see if you've been following me. Type 3 familial hyperlipidemia, type 3 now, is characterized by high IgL. True or false? True. Everybody says true? That is true. Hypercholesterolemia can result from hypothyroidism. True. Yeah. True. Thank you. And then according to NCEPT or 83 guidelines, borderline values for lipoproteins are for LDL cholesterol, it should be less than 100, correct? Borderline. Or normal. Okay, I want to make a distinction now. Okay. There's a difference between something being optimal and normal, and the other one being just borderline high. When you say borderline, that means it's high, but not. You don't need to go and talk to your lawyer that the end is coming. No. But it just means watch it. So that means your borderline. So let me go back here and see, so I can tell you what you mean. So here, look at the borderline here. Though the optimal level is supposed to be 100, 100 to 129, okay, just say watch it. So, and when it gets to 130 to 159, you say, hey, I don't think you are doing what you should be doing. So it's borderline, but it's high. Anything beyond that now becomes high. That's the meaning of borderline, right? And if you look at triglycerides, you see that once it passes the 150, but has not reached the 200, it's borderline. That means still okay, no need to panic, but just watch it. That's what it means. So let me go back to this now. So would you say borderline value for LDL cholesterol is less than 100?
Yes.
Okay. Less than 100 would be normal or optimal, okay? And then what of total cholesterol? 150 to 189. Would that be borderline? For total cholesterol, would that be borderline or optimal or no? What should be the value of total cholesterol? Less than 200. Less than 200. So if you have 150 to 199, would that then be borderline? That's not borderline. That is normal. That is still normal. Is everybody with me? Okay, all right. Thank you. So, what are the strategies for treating dyslipidemia? The recommendation comes from large group of studies as normal. So, and according to these guidelines, the first thing to do is to practice therapeutic lifestyle changes. It's just the same that we do for hypertension. Lifestyle changes can go a long way to reduce hypertension in individuals. And what are these lifestyle changes? Dietary. I was going to come with a slide, I'm not sure whether I've used it for your class in the past. There's this huge guy, you know, he was mowing the lawn, okay? And he drove the lawnmower, you know, the drivable one. He drove it to the window of, you know, I think McDonald's or something. And then he ordered Big Mac, you know, from the window. Ordered the Big Mac, and then ordered for Diet Coke. And I don't know how you ordered for this thick layer of steak, you know, and then you follow it with Diet Coke. I don't know the meaning of it. Don't know what to diet. So that means even for him to walk to the window and park the truck there, he still needed to stay at the window to ask for Big Mac. So that's where the diet comes. Over time, you eat this, the fatty streak builds, and then it becomes plaque, then it includes the vessel, and that's what comes. And that's why dietary changes will go a long way in treating dyslipidemia. Of course, weight reduction, because obesity is one of the major risk factors for dyslipidemia. You need to do that. Stress reduction, and I don't know how many of you know the connection between stress and dyslipidemia. Who can give it a shot? I want us to be practical now. You can give it a shot. When you are undergoing stress, you tend to put on weight. How many tend to put on weight when they are undergoing stress? Everybody?
Because you
No,
eat
so-
when you're stressed.
Yeah, you eat when you're stressed. Okay, all right, that is true. You cannot leave the fridge alone. Okay, so that's one of the reasons for which stress leads to hyperlipidemia. The other part of it, though, is people that are stressed actually don't like to go out, they don't like to do anything, so they just become couch potatoes. So, sit down there, no exercise, nothing, you're eating this on top of that, that's another thing. Then there's a particular hormone, well, one of the hormones, major hormones released during stress. What's that hormone? During stress. And that's where you get another pointer. That's a major hormone that's secreted during stress. Okay, it's corticosteroids. Cortisol. And what cortisol does to you is actually, it leads to this dyslipidemia. So it's a combination of things. One, when people are going through stress, you tend to eat more, you don't no exercise, no interest in any outdoor activity, but more importantly, it's also that the levels of cortisol build up badly in the body, and when you study when the latter part of this course, the second part of this course, pay attention when you do endocrine to the various features of cortisol, then you get it. Now, okay, cessation of smoking will help, and of course, increased physical activity will help. When it comes to dietary approach, you got to make conscious effort to reduce serum lipids and maintaining body weight as a first step. But for individuals who are overweight, they need to go on a weight control diet that is low in cholesterol, low in total fat, and saturated fat, but rich in fiber content. Low cholesterol, low fat and saturated fat diet, rich fiber diet. But for those ones who are sensitive to dietary triglycerides, because they are deficient in lipoprotein lipase. Lipoprotein lipase is the one that's involved in lipolysis that breaks down fat. So these individuals have a deficiency of this enzyme, so they cannot metabolize the fat the way they have to do. So in that case, the diet that is extremely reduced in total fat is recommended because they do not have this enzyme. So they do not have the luxury of even just reducing the saturated fat. They just have to eliminate it completely. Now, what are the risk factors to eliminate as a way of treating dyslipidemia? You've got to treat for diabetes, treat for hypertension, treat for hypothyroidism, treat for alcoholism and cigarette smoking. And when it comes to drug therapy, you just have to use drugs that will reduce the amount of cholesterol. When you are reducing the amount of cholesterol, there are two strategies. One is to avoid the buildup or to avoid the synthesis of cholesterol or reduce it. The other one is to reduce the absorption of cholesterol, and the way to do that is to enhance the clearance of the cholesterol from the system. So those would be the two major approaches, and that will lead us into the drugs and the agents that are useful in the management of hyperlipidemia. There are 7 groups of these agents, 7 of them, and they act on different segments of the cholesterol thing. But just to make it a little easy for you as I go along, keeping in mind that to treat cholesterol, you avoid the synthesis, or at least inhibit the synthesis, or you inhibit the absorption, or increase the clearance. So let's say cholesterol this is the synthesis, there's a particular enzyme that comes in to play, IMG-CoA reductase. IMG-CoA reductase is the enzyme that is involved in the synthesis of cholesterol. The substrate is acetoacetic acid, acetoacetic. So when the cholesterol is synthesized from acetoacetic, something happens. The cholesterol can be transported to the GI tract. So this should be transport of the cholesterol into the GI tract. When it gets into the GI tract, it can go to the liver. And for it to reach the liver, it goes through the agents of bile acids. And I was the one that taught you about GI tract, and know that bile acids, what they do is to emulsify fat in order to remember that. So the way you handle fat in digestion is through the activity of bile acids. So the bile acids will transport the same cholesterol to the liver. So which means, and then of course from the liver, it gets transported back to the GI. There's a certain loop here. And when you talk of enterohepatic circulation, remember that? You've heard of enterohepatic circulation? No one in this class has heard of that. Yes?
It's been a long time.
It's been a long time. Could that be 4 years ago? Huh? Could that be 4 years ago? When did you start the program? Yeah? You made it sound as if you've been in school for. All right. So enterohepatic circulation just means from the intestine, entero, it goes to the liver, enterohepatic circulation. So the cholesterol will be going in that cycle there. All right. In the process of the bile acids being transported, some of the cholesterol that is bound to the bile acids will be reabsorbed into the body. Don't forget the body still needs reabsorbed cholesterol. Okay? Forget that the body still needs cholesterol, so it does not allow everything to go and store in the liver. So there's some form of cholesterol that's being reabsorbed. So now, which means there are two types of cholesterol there. There's what you call dietary cholesterol. It's the one that you have taken through the diet, ends up in the GI tract. Then there is the one that is called biliary cholesterol. That is the one that is bound to bile acids. We call it biliary cholesterol. And because the one being transported in the bile goes to the liver, you also have what you call hepatic cholesterol. Hepatic cholesterol. And I'm taking this step to let you know, so when I go into some of these, I biliary, I don't want you to be confused. In the overall scheme of things here, you have one particular receptor that is tied to the bad cholesterol. We call it LDL receptor. So what the LDL receptor does is to mock cholesterol from the system. It's the one that's involved in the clearance of cholesterol from the body. So the LDL cholesterol will mock cholesterol anywhere you find it, either as if synthesized, or as it's being transported, or as it's being absorbed, anywhere it sees cholesterol, the LDL receptor does that. So one of the drugs that would be useful in the management of, one of the groups of drugs that would be useful in the management of cholesterol are the ones that increase the content or the expression of this receptor. So when these drugs increase the expression of this receptor, it allows cholesterol to be cleared from the system. Do you understand what I'm saying? Taking this step because I want you to get it before I go into the biochemistry of some of them. And I don't want you to get confused. Right? So this is what I'm for you. Now the last thing is this. When the cholesterol eventually gets to its terminal point, so to say, we then have them continue to form fat. Now this fat is the one that's causing the problem of the hyperlipidemia and hypertriglyceridemia. So there is an enzyme, or there are enzymes that will metabolize the fat. We call it fatty acid oxidase, FAO. Fatty acid oxidase, FAO. And what does fatty acid oxidase do? What does it do? It oxidizes the fat and yields fatty acids. Fatty acids. So if you have drugs that stimulate this enzyme, it's helping to break down the fat and helping to eliminate the high fat content of the body. There's another one. Lipoprotein lipase. Lipoprotein lipase, I was telling you before, what this one is breaking down fat. This process is called lipolysis. It's breaking down fat. Lipase.
Now, does that
Lipolysis.
give to anything?
Huh?
Now, does that give to anything? Does that yield to anything?
Oh yeah, no, the lipoprotein lipase, yes, will now lead to triglycerides. Lead to triglycerides. Okay. I think with that, I've set the stage to make you understand some of the concepts we'll be covering here. Do you need me to explain anything here before?
So what does HDL play a factor in there?
The HDL will. I'm trying to simplify a complex story. So because if it's in for, since you need high levels of HDL but low levels of LDL, it will not, what I'm talking will not feature directly in this one. I will just confuse you. Just want you to have a general picture of why we are here. So as we now go into the hyperlipidemic agents, this is what I need you to now know. The agents that will therefore be useful in the management of hyperlipidemia. Will it make sense that there should be agents that will inhibit the synthesis of cholesterol? Makes sense, right? So we want to block at that point. Would it be agents that will inhibit transport of cholesterol to the GIT?
Yes.
That would be another side. Will it be agents that will disturb the transport of cholesterol to the liver? So we will have agents that will attack the binding of the fats to that one too.
To prevent reabsorption?
To prevent reabsorption. Okay? Prevent reabsorption. And of course, you will need agents. Would it be agents that will stimulate this or agents that will inhibit this?
Stimulate.
Stimulate. Okay? Great. You are following me. What about here? Do we need agents that will stimulate lipoprotein lipase or will inhibit it?
Inhibit.
No,
stimulates, cause you need it.
You need like this again?
To break down.
Oh, okay, that's it.
Okay? Then, for the big LDL receptor that will clear the cholesterol from the system, we need agents that will increase the expression of this receptor or agents that will reduce the expression of this receptor.
Increase.
Now my job is done. So let's now go to these different classes. So that's how you end up having one group that will be inhibitors of cholesterol synthesis. The another group that will be sequestrants of bile acids. I mean, the sequester, you know what to do to children. Take them away from their family, sequester them. Okay, so then you have cholesterol absorption inhibitors. Then you have PCSK9 inhibitors. Then you have fibrates. You have niacin. This one, 5, 6, 7, they all act here. Am I clear?
Yeah.
Clear. Okay. So now, yes, ma'am.
Are you saying this mechanism right there helps increase HDL?
They will increase HDL. Help increase HDL. Okay. And as you go along, you'll be seeing some little different. That's why I said I just set this stage to let you have a global understanding. Because it's a lot of biochemistry, and I don't want you to be lost. So now, because we have different lipoproteins, each of them have a primary action on some of them. Of course, you're not going to end up with a situation where one group is just focused on one particular lipoprotein, but they will have greater effect on the lipoproteins. Okay, for example, the LDL, these 4 groups, they act more on the LDL. So you might be seeing like a 60% reduction in LDL, a 5% increase in HDL, and a 10% in very low density lipoprotein or triglycerides or something. But this is where they target primarily. It doesn't mean they do not affect the other lipoproteins. That's the point. The fibrates and niacin, they produce more effects on HDL. And the omega-3 fatty acids and the fibrates and niacin, all of these are more for hypertriglyceridemia. So when the purpose of doing lab tests for patients who are presented for, let's say, hypercholesterolemia, is to know what specific class of lipoproteins or lipids they have much higher. So if you find out that the patient has more triglycerides, there's no point starting the patient on this. That's what it means. And if the patient has more of the LDL, there's no point starting the patient on any of these. Okay, so that is that. Now let me talk about the PCSK9 inhibitors before I go into it later on. These ones, what they do is they inhibit the degradation of LDL receptor. See, the LDL receptor can be degraded by the enzyme PCSK9. So PCSK9, this is a degradation product. It's a degradation exercise. But we know that we need more of this. So does it make sense that we have to inhibit this enzyme, right? We have to inhibit this enzyme that is causing the degradation of what we need. That's how you end up with the PCSK9 inhibitors. When you are able to do that, then you are able to reduce the amount of cholesterol because it can clear the receptor, it can clear the cholesterol more. And that is what you have here. Let me deal with the first class of agents before we go little break. So I want to talk to you about inhibitors of cholesterol synthesis, and this is where your statins come. Statins will inhibit cholesterol because they are competitive inhibitors of IMG-CoA reductase. So this is here where you have statins. They compete with this enzyme because this enzyme is the rate limiting enzyme in the biosynthesis of cholesterol. That's the mechanism of action. And they are very effective in lowering total cholesterol and the bad cholesterol. Generally, the statins will decrease LDL, see the percentage, was up to 55%. The triglyceride they do to much less extent, which is 10 to 35%. And they can increase HDL, but very, very minimally. So when the patient has very low HDL, you don't go for statins because the effect is too little. You reserve it for the use of this. Now, why is the statins competitive inhibitors? You know, there must be a structural resemblance. It's because they have a side group that is structurally similar to HMG-CoA reductase, and Dr. Chenya will tell you more about that. So when they reduce cholesterol, they do so by inhibiting the synthesis in the liver. And let me go to the next slide that you just pointed out, so not this one. Okay, this is the synthesis of it. It starts with the acetyl-CoA and acetyl-CoA. This is where the enzyme comes in, and this is where the statins go in. And of course, the biosynthetic pathway of cholesterol that Dr. Shivasha would have told you is all of this. So when the cholesterol, when you're giving the statins and the cholesterol level has reduced, something happens. There's a transcription factor that's affected. This transcription factor is called SRBP. It's normally inactive, but the lowering of the cholesterol will activate a protease that activates this transcription factor. It becomes active, moves into the nucleus, and combines with the LDL receptor gene in the nucleus. It then gets out of the nucleus into the cytoplasm again, where it now causes an increased expression of the LDL receptor. Of course, with the increase in the LDL receptor expression, we have an increased uptake of plasma low-density lipoproteins, and the amount of LDL in the system is reduced. You get that?
Mm-hmm.
Okay. So, just know that when the statins act on this enzyme, they eventually reduce cholesterol. It allows the activation of this transcription factor, SRBP, which translocates into the nucleus to activate the LDL receptor that moves into the cytoplasm, causing an increase in LDL receptor expression. And the LDL receptor expression going up means cholesterol level, low density level, lipoprotein level in the system is down.
Would you like us to know the biochemistry of that?
You say what?
Would you like us to know the biochemistry of?
Oh, no. I'm not going to do that to you.
Okay.
No. You have sufficient trouble understanding this. So I will not give you the biochemistry of it.
Okay.
So now, back to what I've just explained. This is what I've explained. The reduction in the cholesterol affecting the transcription that protein. What does it do? It affects the expression of the gene in the nucleus, which leads to the expression of the receptor. Then leads to increased removal of LDL from blood, and that's how you decrease the LDL concentration in the blood. And of course, it says besides reducing LDL cholesterol, numerous trials, clinical trials have shown that statins are very good at reducing mortality after the myocardial infarction. This is the same information, but put in another way. The important thing is you inhibit the enzyme, you increase expression of the receptor, you cause an increased clearance of cholesterol from the system. What are the contraindications to statins? Pregnancy, and then nursing mothers should not be given statins. The last information on the statins is this slide, and is that apart from reducing the LDL cholesterol, statins are known to have a number of other effects on so many other organs within the body. Good ones too. For example, they are known to reverse endothelial dysfunction. Endothelial dysfunction is what predisposes to hypertension and atherosclerosis. They will decrease coagulation. They are anti-inflammatory, and they are known to improve the stability of atherosclerotic plaques. What are the different types of statins? Lovastatin, pravastatin, simvastatin, fluvastatin. Where's Brandy? Oh, you are Brandy. Okay, there's Brandystatin too. So anytime you have statin, that's everything. So the major adverse effects linked to statin use, as good as they are, is because they always come up with muscle pain, muscle myopathy. So patients that are on statins complain of muscle pain, and this is because there's rhabdomyolysis. Rhabdomyolysis is a condition where it involves breakdown of muscle tissue. With the destruction of skeletal muscle tissue, patients feel pain from the use of statins. So help me say true or false. Statins possess anticoagulant activity. True or false?
In regards to the one pregnancy and nursing mothers, you said we should give them. Is there any reason for giving them statin?
No, it's because they have some form of in the babies, in the unborn ones, it could cause some malformations, and I think in the newborn babies, they tend to have some issues even with their skeletal muscle stability too. It can get transported in the milk and affect the baby. Then, do they have anti-inflammatory effect? Yes, they do. And so I will, you need a break or I should continue? No, you don't need a break. So, all right. I can give you 5 minutes if you want, or 10 minutes, but.
5 minutes. Let's go down. It's too much.
All right, okay. It's too much? Okay, all right.